Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the NARM Training Institute. I'm your host, Sarah Buino, and I'm delighted to have you join us today. The NARM Training Institute is offering a Level 2 NARM therapist training online so that you can attend from anywhere. The trauma field is evolving so quickly. Trauma-informed therapists who want to learn how to address the long-term impacts of adverse childhood experiences and complex post-traumatic stress disorder want to be trained in NARM. This online NARM therapist training is starting in April 2021 and July 2021, and they're filling up fast. So if you're interested, we'd encourage you to register now to reserve your spot. For more information and to register, please visit www.narmtraining.com/level2online. We look forward to you joining our growing international NARM community and are inspired to work with you to bring NARM to your clients and communities in order to transform trauma. I think you'll enjoy listening to today's guest just as much as I loved speaking with her. Veronique Mead was an assistant professor of family medicine and a practicing physician when she decided to change careers and retrain as a somatic trauma therapist. For the past 20 years, she's been integrating science with her personal journey of gradual recovery from disabling chronic fatigue syndrome. She applies that integration to a new model for making sense of chronic illnesses of all kinds. The research explains how effects of trauma are not psychological, as is still often mistakenly believed. She shares the science on her blog, www.chronicillnesstraumastudies.com. So please enjoy my wonderful conversation with Veronique Mead. Veronique, welcome to Transforming Trauma. Hello.
Hello to you, Sarah.
Thanks for joining us today.
Oh, great to be here.
Yeah, and no one can see this, but I'm quite enjoying the lovely, are those like a lily pad drawing in the background? Painting?
Yeah, they're watercolors I've played with.
It's very beautiful. It's very soothing for me to look at, so thank you.
My pleasure. The little things, right?
It is the little things. Absolutely. Well, before we dive in, we love to ask all of our guests on Transforming Trauma the question of what is it that you would like guests to get out of our time today?
There are a few things. One is that this complex PTSD, this concept of early adversity, is so much more subtle and common than we think. It's actually an important risk factor for chronic illness. And two other things are that it's not psychological, which is a really common misperception. And the fourth is this sense that symptoms are actually really intelligent, that they are survival pathways that have gotten caught in states of fight, flight, freeze, or some combination. And that's sort of a different way of thinking about chronic illness.
And that's very aligned with NARM, so we're going to get along swimmingly today.
Sounds good.
Great. Well, why don't you introduce yourself a little bit more deeply and tell folks who you are and what you're up to in the world?
Well, I was a family doctor 20 years ago and had a practice that included obstetrics and kids, people of all ages. I was an assistant professor, taught medical students and residents. And I left medicine at the very beginning of the onset of my own chronic illness, which is chronic fatigue syndrome, also known as ME/CFS. But it wasn't because of this fatigue that was starting. It was a sense that I didn't really have good tools for working with people with chronic illness. I have more clarity about that now than I did back then. But back then, there was something that really wasn't sitting right with me, and that I really felt something was missing. And I was actually having a lot of despair and a sense of meaninglessness in my life. And I was just starting to work with a therapist. He was a body worker, a Rolfer. Our sessions were an hour and a half long, which all I'd known really was my medical training. And it was the most amazing experience, as was his ability to listen. Oh, it was amazing.
Don't get that always in the medical field, do you?
No, this rush and the never enough time.
Right.
And so working with Kevin introduced this concept of listening to myself and my symptoms and my body and my impulses. And that was completely new to me back then. And through a process of starting to do that, I was able to notice how I was feeling practicing medicine and the idea of leaving. And so I ended up taking a year off and then retraining as a somatic trauma therapist at Naropa, something I hadn't even really known existed before then. And then I learned about trauma, which was something really, as a physician, I thought about it as really purely linked to the big stuff. And it was really about the psychiatric PTSD and maybe other chronic conditions. But I never really thought about it as having anything to do with the medical side of things. And so when I retrained and I started learning about how much more complex and subtle and everyday trauma is, really as a definition, I think about it as anything that is overwhelming enough for us that we're unable to overcome it or adapt to it. It's that simple. So as I was learning that, I had a class, I was writing a paper one day, and I was looking for an example because I was kind of curious about chronic illness. And this concept in somatic psychology, which I've heard you talk about in a previous interview, is how things can get interrupted, how trauma can interrupt a cycle that's trying to move through fight or flight, for example. And that if you truncate something or you cut it off in cycle, that cycle can get stuck at that point.
Right.
And it made me think, what if a fight-flight response gets stuck where your blood pressure is elevated as a way to help you mobilize through something?
I never even thought of it that way, but duh.
Right?
Right. Duh.
That was the big aha curiosity that happened for me. And I also thought, well, what if blood sugar gets released when we're mobilizing to help fuel the muscles for everything we need to do to run away or fight? Well, what if you truncate a cycle, a metabolic, physiological cycle there? Could that end up leading to either kind of diabetes, an autoimmune form that's a particular orientation to actually minimizing the amount of blood sugar, maybe because your system's trying to, I don't know, be in a freeze response? Or maybe because your body's actually increasing the insulin resistance as a way to protect yourself. And so that launched me on to the past 20 years of curiosity, where I started looking at the research with the simple question of, is there any evidence that trauma or adversity is a risk factor for any kind of chronic illness? I now have 12,000 references.
Is that all? Just a handful.
Just a handful. I can't keep up the amount of information that's out there. And it's still not at all a perspective that we have in medicine or that's being taught in healthcare, in medicine in particular.
Right.
So that's my brief background about how I've got interested in this sort of link between trauma and chronic illness and why it's not psychological.
Have you listened to the episode with Dr. Heller and Christina Bethel?
Not yet.
Check that out because I hope I'm doing her justice. She works in the research field and is essentially trying to pair research with policy and getting things changed in the medical field. And right now, she and Larry are working on something in order to essentially make trauma training part of pediatricians' work, so that we can catch it early, right?
Yes.
Like, wouldn't that be amazing and just change the game?
Yes. And the whole research already on adverse childhood experiences, or ACEs, is starting to change that game. And there are pediatricians and internists and family doctors who are beginning to incorporate it into their practices. There's some studies looking at what it's like if medical students get trained for a few hours in understanding ACEs. And my own sense is it needs to be incorporated from day one through the entire training, through every module, through every specialty rotation that everyone goes through as part of a trauma-informed view of how we interact with people as people. rather than
Right.
patients, for example.
Well, and even in, I can only speak to social work because that's my field. Even in the social work field, actually, I teach an addictions course, and the new book that we just got that I'm going through, I realized there's literally no mention of trauma. And so I had to tell the dean, like, we're going to need to supplement because we absolutely have to talk about trauma. So if we're not talking about it in the therapy professions, of course, we're not talking about it in the
Yes,
medical field. All of these things need to go together.
they do. And that's a really big point, is that that would be the place we would think would be the most informed about trauma, would be all the different kinds of therapies. And it's not there either. And a lot of therapies are part of a very traditional model that fits within that medical model that doesn't yet understand or see or recognize even the link between life experiences and how they embed into our biology through epigenetics and nervous system development
Right.
and that whole process early in life in particular.
Right. Do you have a fantasy of what you would like to see in terms of? Well, I mean, you already did say a little bit that it needs to go in like every sense of the field, but I guess I'm thinking more of a systemic change of the way that we think about training doctors, because I have experience treating doctors who come with addiction. And, just so I've learned a little about it there. And what I hear that feels problematic to me is this reliance on hierarchy, this training to teach them that they have to always know the answer, which doesn't leave room for curiosity and humility, right? So I'm kind of thinking like more of, I don't know, like the values of the medical field. Does that make sense?
It really does. My role model when I was in medicine is a pediatrician, Naomi Remin,
Hmm.
who wrote the book called Kitchen Table Wisdom. And she was in the traditional way of working as a pediatrician for many years, and also had a similar process happening for herself internally that led her to change. She ended up taking courses at Esalen, working on herself. She has inflammatory bowel disease, IBD, which when she was a kid, she was diagnosed at 12 or 13, I think. And life expectancy is about 40, or it was about 40 when she's about 80 something now. And she ended up working with herself and her symptoms from these whole different perspectives that include recognizing and making room for intuition and the intelligence of our system. And she taught courses to medical students. And in her private practice, she worked with physicians who are experiencing burnout and people with cancer. And part of all this comes back to a big piece I got from her work and her book was people go into healthcare because we want to help others. And our training tends to lead us to want to fix others. That's the very traditional model that we have right now.
Yes. Yes.
And people who go for healthcare of any kind have been given in this expectation that they can and will be fixed.
Right.
And so there's this huge expectation that
Right.
one person has all the answers. And so the problem with that is that it doesn't only potentially traumatize those of us who are going because we need help figuring something out. It's actually really, I think, traumatizing for physicians and other healthcare professionals. The suicide rates are really high. They're higher than the general population. And the burnout rate is also really high. And I might have thought I was burning out, but really it was a change of philosophy that I needed to do that I wasn't fully clear on at the time. So your original question about if I was to fantasize about how it would look, it would start from day one, and it would start with connection and helping the students begin to first look at connecting to themselves, which I think a lot of those of us in the healthcare professional have experienced some form of trauma. That's part of why we go into this, right?
Yeah, I'm nodding emphatically.
And we often specialize in the things that have been our own major issues.
Right.
And so if they were to then from that place learn and explore their own trauma histories, learn about the science, and start with the expectation that they do their work of healing as part of how they contribute to working with others, it would start to open their eyes in a whole different way.
Well, can we be best friends? Because this is literally all I think about and feel and talk about. We're just so on the same page with this. I mean, literally any profession, if you do your own work first, that inside out process. I mean, and this is what NARM is all about, really, getting clear on our own survival strategies as therapists and helping, be able to like maybe put them to the side in order to see a client clearly. Like, gosh, how the world would change if this is how we were approaching it.
Yeah.
I'm also just thinking, this is a little off the topic, but I'm just thinking just how that's such a feminine way of approaching medicine, right? About connection first, that relational piece, that like looking inward. Whereas right now it's very patriarchal, right? Like, I don't want to get too political, but we're really being called to this more feminine, energetic shift, aren't we?
I think we are. And I think a lot of it comes from that feminine aspect we all have that needs connection.
Right.
Because as a physician, I had no idea I was lonely.
Oh.
Right?
I want to pause with that because that's because our culture is often not allowing us the time to stop and pull back and really be with that. Wow, that's huge right there.
Yeah. And part of the whole concept of the training is, in a way, that you have to be strong.
Yes.
What you said before, that you have to know the answers, that you need to buck up and not get weak with what you witness, which is essentially you're witnessing trauma all the time with people's losses and their own suffering and their own pain. And so understanding trauma could really help shore that up in the community as well, for men and women and the non-binary, for everyone.
Exactly.
Because connection is really what gives us the strength to face whatever we need to.
Yeah. Thank you for saying that way, because it's not about gender. It's more of an energetic quality.
Yeah. And the appeal, and I feel it in my own system, because one of my big survival strategies growing up was being an intellectual, being in my head, disconnecting from my body. And the appeal of our current medical model is we want to fix things. We want to solve problems. And it seems like it should be so linear and straightforward. And
that's the lie they've sold us, right?
It's so messy.
Yeah.
Not linear at all. Yeah.
Well, I feel like I could continue expanding into the macro, and then that's going to get probably too political than we want to get in this space. So let's bring it back to kind of more of the micro and the work that you're doing and what you're seeing essentially with folks who are coming in with chronic illness. Are there any themes, anything in particular you really want to talk about?
Yeah. So at this point, I do not work with clients anymore. I blog. And I've been disabled from my own chronic illness for 20 years, and disabled enough to not be able to do psychotherapy for 10. And I've been working with my own chronic fatigue syndrome from all of these perspectives for 20 years now. And I'm doing much, much better. But I don't yet have that nervous system capacity to help regulate another nervous system and do trauma therapy like I did before.
And what a gift that you are able to recognize that and give yourself permission to do that.
And to have the support to do it.
Right. Yes, the privilege to have the
huge.
support. Yep.
Yes. Yeah.
Yep.
So actually, over the past 20 years, I've been pulling together the research, and I've kind of think of it, I don't know if you would call it a model at this point, but I think of it as being at least 8 categories of adversity that influence risk for all kinds of chronic illnesses. And that by breaking it down into different categories, it can kind of help us all begin to grok a little bit what may have happened in our own lives that may have influenced our risk, because it's so subtle and difficult to recognize.
Thank you. That's been the biggest gift from NARM, is recognizing the subtleties. And there are so many people walking around in the world thinking, I didn't have trauma, just because of the way it's been defined in popular culture.
Exactly. And, to take one example, the adverse childhood experiences, the ACE studies look at 10 very specific types of trauma that happen before our 18th birthday. And Some of these are classic of what we think of as trauma, emotional, physical, or sexual abuse, for example. But they go beyond that and also look at emotional or physical neglect. If you have a parent who has a mental illness or who is struggling with substance abuse or any kind of addictions, really, or if you're a witness to domestic violence between your parents, or if you've had someone who's gone to jail in the household.
And divorce.
Thank you. I knew I was missing one.
There's always one, right?
There's always one. And divorce, given that 50% of people get divorced in our culture. I mentioned it to someone once with a chronic illness, and it really didn't land. There's so much divorce and there's so much of their particular chronic illness. How could they possibly be linked? And what this whole ACEs field is learning is that these kinds of early experiences actually affect how our genes function through epigenetics, because our life experiences attach and detach molecules to the genes, so they turn them on and off. And that's just one physiological way that our life experiences influence our long-term health and shape it. The thing about the ACEs that kind of caught my eye, there were a few things. One was when I first read that article, I had finished my degree at Naropa, so I'd been out of medicine for at least 5 years before I read it. And it just didn't seem to apply to me.
Right. I thought the same.
You did too?
I did, yeah.
Yeah.
Except for divorce, I was like, no trauma here.
No big deal.
Yeah.
Right. And so it also didn't include my chronic illness of chronic fatigue, which I probably didn't have a name for at that point.
Yeah, they don't have fibromyalgia and all those other,
No autoimmune diseases are named in there.
Yep.
And so you can think, okay, well, I don't have that chronic illness and I only have one of those, so not related to me. And for years, even with my extra training in trauma, I trained in somatic experiencing and sensory motor psychotherapy and perinatal work, I thought my ACE score was 0. And that is also really common.
Right. And a problem.
And a problem. Right. Yes, because all of these things within the ACEs, we often think they had it worse, couldn't have been what happened to me.
Yep.
Okay, so my parents squabbled. That doesn't count.
Right. Because that's not on the ACE study. Exactly.
It's not domestic violence.
Yep.
Yeah. And what I came to realize was talking with my parents was one of them. I was talking with my mother one day, and she told me that she had never cried as much as she did in my first 2 years after I was born.
Whoa.
Her father died when I was just a little over a year.
Oh, wow.
Yeah. She moved to another country when she was pregnant with me. Cried when they got to the big city because it was really ugly. She didn't speak the language. And so I would call that postpartum depression.
Yeah.
Or depression. I just don't think of that as mental illness. We tend to think of mental illness as the really big, severe, serious stuff. So that's actually an ACE for me.
Right.
And the other one's taken me longer to recognize. And it's partly been through the help of my husband, partly through tons of my own work and his feedback that I myself was disconnected. I can connect briefly in short term quite well, but that long term intimate relationship is much harder. And what I realized was that emotional neglect was another ACE for me.
You know, I'm thinking something that isn't fully formed yet, but so I feel like as a society, we're finally starting to shift away from binary, concrete answers, away from the yes, no, black, white, right, wrong sort of thing. And we're expanding into more of a gray, non-binary area. And I wonder if that lens coloring things a little bit differently creates more space for us to see ourselves in the ACE study, right? Like, can we expand the language? Can we adapt the language? You know, because our understanding of trauma now is different than it was when they did this study, right? I mean, the trauma field, I feel like, is advancing at like light speed, right? So, but there's something too there, I think, with like our expansion of understanding things outside of the simple categories that we really want to put them in.
Yes. And that's actually part of why I now am thinking about things in at least 8 categories of trauma. And I
Yeah,
think of the
talk about
word,
those categories. I want to hear those.
yeah, so categories to me feels bigger and more spacious than types of trauma as one thing.
Mm-hmm.
And space, when you mention space, I mean, that's such a huge resource in working through our trauma. If we had enough space, that is sometimes enough to help our bodies do what they're designed to do all on their own. So the 8 categories, I have huge respect for what the 10 ACEs are doing because they are changing the landscape and the conversation. And in an email exchange with Dr. Filiti, who's one of the co-investigators of the ACE studies, he recommended adding an 11th question. Is there anything else that might have affected you or that you might have experienced?
It's a good catch-all.
It is a good catch-all. And I felt as though I wanted to really expand. And so I've been using the term, and I checked this out with him, he was fine with it. I've been using building all in the same wording. So I think of adverse childhood experiences plus, ACEs plus, for all the stuff that doesn't fit in ACEs before your 18th birthday. If domestic violence in the original ACEs is about the father abusing the mother,
which is very heteronormative.
exactly. So ACEs plus could include the opposite, or actually any violence happening between any family member.
Right, because it could be siblings. It could be...
Yes.
Yeah.
And we know that witnessing trauma, whether it's visually or auditory or in any way being around it, is highly potentially traumatizing for us as the witness. But so it also includes things like accidents, hospitalizations, if a parent has a chronic physical illness. And so that's ACEs plus as a second category. And then as I looked at my own sense that I had no ACEs, it made me call this whole other category invisible ACEs at first.
Ooh.
The relationship, this concept of complex PTSD, the experiences we have in relationship with our parents, whether we feel seen or heard or attuned to, that I've given it its own category. And emotional neglect, that one ACE, is kind of part of this, but I've expanded it. And
exactly. Yes.
Yes.
This is where NARM swims. So I'm just super into
yes.
it. Mm-hmm.
Yes. And in ACEs, just to go back to that for a moment, any ACE carries the same risk as any other. I think they did find that some were worse or carried more risk, but ultimately when you add up how many of the 10 ACEs you've experienced and you get your ACE score out of 10, it doesn't matter which ACE you count, it carries the same risk. So me with an ACE score of 2, I actually have, from one of their studies, I actually have a 70% chance of ever being hospitalized for an autoimmune disease.
With just 2?
With
wow.
just 2.
Wow.
If you had a parent who had postpartum depression and your parents got divorced, both of which are super common. And what that begins to highlight, I think, is how common the role of adversity may be in chronic illness, because 50% or more of the population in the US has one chronic illness or more.
Really?
Yeah.
Wow. And I would say all of us have trauma of some sort.
Yeah. Just that we haven't yet recognized it enough. So to get back to that category of emotional neglect, it's clearly important. And there are studies such as type 2 diabetes, for example. 35% of people in the US have type 2 diabetes. It's the most common form, doesn't require insulin for most people. It's often thought to be linked purely to being overweight, having a overeating and inactive lifestyle. That's the common view that's on like the WHO website. But I heard you quote Filiti's very first experiences were working in a weight loss clinic and discovering by doing interviews with people who had lost weight and then gained it back, that a very large proportion of people with bigger bodies had experienced some kind of adversity in childhood. And sexual abuse was part of it, but their household dysfunction was, all these other things were part of that too. And he was so floored with that. And he thought, oh, this will change medicine. And then crickets. So that led to the ACEs study. And looking at type 2 diabetes, I've just written a blog post looking at research in all the 8 categories of adversity. There are 8 categories of adversity and research showing risk for type 2 diabetes, and that all of these, starting with ACEs, for example, are risk factors for having a bigger body, risk factors for potentially using food as a comfort or soothing and not in a conscious way, and risk factors potentially for being more sedentary because of having a freeze response.
You're on to something.
It just goes from there.
Right?
Yeah.
Oh my gosh.
So the emotional neglect ended up being, some researchers looked at ACEs as risk factors for type 2 diabetes, and neglect, emotional or physical neglect, looked like it was the most important risk factor for type 2 diabetes out of all the ACEs. So I call this category that really fits with complex PTSD. It's the same category. It's just this term hasn't been that familiar for very long yet, even though it's been out for a while. And I call it adverse childhood relationship experiences, or ACEs. And in my work, when I was working with clients who tried psychotherapy, but also in the conversations I have with my readers on my blog, I think this is the most invisible, under-recognized risk factor for chronic illness and all kinds of effects of trauma. That's 3 categories there. And in adulthood, I think of 2 more categories. One is some chronic illnesses start in childhood, many start in adulthood, and it's often after a period of time where there have been all kinds of adverse experiences. It could be job loss, it could be divorce, it could be conflict in relationships. And those are often stressors that could also be traumas, accidents, injuries, it could be medical procedures. And for some people, they'll have these experiences over a number of years or a decade, and then one final event will trigger the onset of the chronic illness. So I think of the event that triggers the onset as adverse pre-onset experiences, APOEs, because this is really common in the literature. And this is often the first thing that helps people even begin to think of trauma. It's like, wow, I developed my type 1 diabetes after a car accident, or my lupus started after my surgery. And that can get people to begin to look. There's other research also looking at infections, mold, exposure to toxins. It's called the cell danger response. It's by a doctor at UC San Diego, Robert Navio, who calls it, so the CDR, the cell danger response, essentially goes to trauma theory. He talks about Porges's work. And what he says is that pre-onset trigger is the last straw. It's not the cause. It's actually the last straw.
That makes a lot of sense. We just had mold in my house, so I'm looking around like, please don't be in the walls again.
Yeah, right. And what you just named is there's the conscious reaction we have, and then there's also the nervous system, unconscious perceptions of threat. And so what he talks about from a study he did with folks with chronic fatigue syndrome actually was that you can fit the triggers into categories of psychological or physical trauma, biological threats such as infections, bacterial infections, viral infections, COVID infections maybe, and toxins, chemicals, pollutants, possibly medications. And there's an unknown category as well, but that he found that most people had pre-onset triggers that fit into those, and that they weren't the only thing. So infections are very common triggers for all kinds of chronic illnesses, but then you treat the infection or you try to do a biopsy to see if the infection's still there. And for many, many people, there's no trace of the infection, or they don't recover when you treat the infection. And Navio's view of the cell danger response is that what has happened is not that the infection caused it, it's that it was the last straw in a years, decades long process where a survival response has been evolving over time. Something that might have been initiated prenatally or around birth with adversity then. That's another category of adversity. Then it may have been strengthened in childhood with other events, or the childhood relationships that were where there wasn't enough resource or support to balance out the adversities and therefore our bodies couldn't recover as they're designed to do. And that then you have these adverse adult experiences, as I call them. That's another category. These 10 years maybe of divorce or stress or job loss that don't trigger the event, but that seem to build on each other. And then that final event happens, the APOS.
Can I ask a question in here that's coming up for me? I don't know if you've looked at this, but do we know what factors influence whether, because if we both agree that everybody has experienced trauma, what factors go into folks who don't end up developing the chronic illnesses? Like, what's the difference?
I think that's a critical question. I don't think we have an answer, but I think there are, it's like what you were talking about. If we give it space and we actually look at it from everything we're learning about trauma, I would say there are a number of possibilities. One is there may very well be a genetic component in that some of us may have predisposition for certain kinds of chronic illnesses because of genetics. And what we're learning about trauma is that chronic illness, as a physician, I never really thought about it, but I kind of assumed that chronic illnesses were purely genetic. And recently, we've been finding out that it's actually maybe 50% genetic or less for most chronic illnesses, and that the other half of risk is all these life environmental factors and that include life experiences. And that those life experiences of adversity may actually be necessary to turn that genetic risk on or off. So if you are someone in a family where a whole bunch of people have a particular chronic illness, let's just say it's type 2 diabetes, that may be the chronic illness you're most at risk for, maybe because it runs in the family. But it may really be about how much nurturing versus adversity you experience in your own life. But then you can also turn that on its head, because what they're finding is that genetic risk for type 2 diabetes may only be 10 to 30%, which means that a huge component is environmental. That would support the lifestyle views, but it also supports the role of adversity. And so another risk factor that may determine whether you develop a chronic illness or not, or some other effect of trauma, is what I call adverse babyhood experiences, ABEs. ABEs are also under-recognized, but like my mom experiences those prenatal stressors. They seem like everyday stressors. They don't seem like a big deal. So she moved to another country and left her social support network behind. But she still had my dad, and she was still fine, But then her father died when I was just about a year old. And during her labor with me, it seemed that it wasn't going anywhere and it wasn't going fast, and she was exhausted. And so a very common thing was then her doctor gave her an epidural, or they do an intervention of some kind. We get worried. We feel like nature isn't progressing at a certain pace that we expect. And so she got the epidural, and I apparently came out right after that, but it was so excruciating. The experience of the epidural was really painful. And then the way trauma compounds, she developed a spinal headache, which is a potential side effect you can get.
That sounds terrible. I'm
sorry.
You
just grimaced your eyes.
Anything with the spine, I'm like, nope. Now my back hurts. All right.
A little levity is helpful, right? As we name all these different hits in a way. And again, if you look at all this from this trauma lens, there was actually, my parents described this bonding experience they had where fathers weren't allowed in the room in the 60s when I was born. But he was allowed in after. And the three of us, apparently, I went through this phase that's actually well recognized of big, wide, open eyes, taking in everything, totally calm. And this is actually where parents fall in love with their babies, if they haven't already during pregnancy. And so this bonding is actually protective, because the more connection we have, the more we can weather things together later in life. And when I developed this concept of ABES, I pulled together a ton of research from different areas. That bond means that parents hold their babies more often, hold them closer, talk to them more, gaze at them more. They're more protective and stand closer to them, like if they're at the doctor's office getting an exam. And these influence our epigenetics, actually.
Wow.
Yeah. Now, in premature babies, we know that kangaroo care works really well, holding the baby skin to skin on your chest. And the parents doing that, those babies grow faster, eat better, their breathing regulates better, their heart rates, and they usually get discharged sooner. And that's actually a form of psychobiological regulation. This is another way that our systems get primed very early on into what direction of development they're going to orient to. Is it going to be a calm, grounded sense of safety and security? Or is our nervous system going to get primed more towards lack of safety, fight, flight, not enough nurturing? Where's mom or dad? I'm in an incubator, that kind of question.
I'm thinking about like
I see the wheels turning.
Right? Yeah. It's funny. Both my parents have passed away, but my mom really loved to write, and she'd written out my birth story. And it's funny not funny, haha, but just funny, interesting to read it. And there was a lot of passive aggressiveness. There was a lot of like anger at my dad because he went to work and all these sorts of things. And so I'm just thinking like, what happened? Because I'm sure that my mom probably did, end up connecting with me. Like, but what was she really focused on at that point, right? Was it actually me, or was it really holding on to the resentment at my dad, or, focus on, like she said, she had children to be loved. And so was that like, trying to kind of suck that love from me at that time? All of this is really, just really interesting to think about. And again, it's so subtle. This is not something that you read about in the books. Like, it's so specific to each person.
It is. And what you describe, I think of these as aids, because our mother's experiences of trauma, adversity, acres, her own relationship with her parents have an impact on her ability and capacity, her nervous system's capacity to relate to us as newborns. Same thing with our dads. Yeah. And there's now research about this. I learned this when I was doing pre and perinatal training, of learning how to work with this and doing my own personal process with this, that we were eggs inside our mothers when they were in the womb.
Right.
About 5 months of age is when her little baby's body forms most of the eggs that she will have throughout her lifetime. And so they're finding this in research in animal studies, that the impact of grandma's experiences influence 2 generations.
Yep. That makes a lot of sense.
Yeah, so that can impact our risk for chronic illness as well. And coming back to the type 2 diabetes gene question, so it can be that there actually is not as high a genetic risk as we expect. Then you add the very early ABES experiences that happen when our bodies and nervous systems and cells are developing and forming. And there's a large body of research known as the Developmental Origins of Adult Health and Disease, DOHAD, also known as Fetal Origins of Adult Disease, FOAD. And
love the acronyms.
Yes, indeed. These started during World War II with a study in the Dutch hunger winter, when a whole population was held under siege and there were no food rations, and so starvation was extreme. They studied the women who had been pregnant during this period of time and found that this kind of prenatal stress has an impact on the baby that can continue for at least 2 generations to grandchildren, at least. They originally thought it was purely nutritional, and that's a very medical model. Physical illness, physical effects, physical starvation. But if you're under siege and starving, you're clearly having intense emotional stress as well, or trauma.
Yep.
Yeah. And these studies have been repeated. Some of the studies have looked at least 20,000 people, followed them for 2 generations. I don't know if that's the specific one, but some have been followed for 2 generations. And what they find is that prenatal stress has an impact, and the risk factors are for a particular group of chronic illnesses, maybe because those were the most common. And these are the diseases linked to type 2 diabetes. These include larger bodies, high cholesterol, high blood pressure, heart disease, and they're all linked to insulin resistance. So the body having an orientation where it doesn't want to use blood sugar in the way we normally think about it. This brings up two more factors about potential risk for chronic illness. One is that the timing of exposure during pregnancy, for example, in the first, second, or third trimester. So in the first 3 months, very early, right after conception, or in that last 3 months before birth, the timing appears to have an impact on what's developing at the time of exposure to stress. So the timing can influence the number of cells in our tissues. It can affect birth size. So babies who are small at birth, those of us who are smaller at birth, have higher risk for certain chronic illnesses, but also for all kinds of other effects of trauma, like depression or anxiety, Alzheimer's, osteoporosis. And we find these with ACEs as well. So it's not the specific type of trauma. It's what adversity does to our developing nervous systems and how they orient to the world.
Yeah, we're going to need to do a part 2, but yeah, I could just keep going with this. We could keep talking forever. So just in the interest of time, is there anything that you really want to leave listeners with today, other than all the brilliance that you've already dropped?
I think that the beauty within an understanding of trauma and adversity, I use the word adversity because for many people, it makes it easier to think about what they might have experienced that doesn't feel like it's as strong or overt as something you call trauma.
I like that.
So I use both terms, but the beauty of understanding how this affects us, how it's not psychological, how life experiences interact with our bodies, I think, is that once we understand this, we begin to recognize it in ourselves and in others. It removes blame and shame and judgment because it's not something we've actually done. It's not because we're weak or lazy or because it's in our heads. And it then gives us all these tools to work with that may really contribute to a much higher, greater capacity for healing, improvement, reversibility, slowing down the progression of chronic illness, stabilizing it so it doesn't get worse, and maybe even reversing it. And there are stories and some research like reversing asthma by healing bonding disruptions in moms. You heal asthma in the kids by healing it, bonding disruptions in moms, trauma. And so I really see it as filled with potential because if you know this about yourself, then there's not one tool. There are whatever tool feels like it could work for you. And there's all kinds of perspectives I think of about what to pick and what fits. And it's about following your own impulse and what resonates with you, but also thinking about how we're working with brain plasticity in our nervous systems. And that if we can shift the perception of threat that's gotten caught, that Navio and the cell danger response suspects and that us folks in trauma look at as potentially being what actually drives symptoms of chronic illness, then there may be a whole lot more encouraging, hopeful, empowering things we can do than we've realized.
Yes, that is a brilliant note to end on. Where can listeners find your blog? What's that link?
My blog is called Chronic Illness, traumastudies.com.
Wonderful. Well, this has just been a pleasure, and I know listeners are going to get so many nuggets out of this. This was just wonderful. Thank you for being here today.
Thanks for having me. It's been a real pleasure for me too, Sarah.
Thanks so much for joining us for today's episode. To find more about our guest, check the show notes or visit us at www.narmtraining.com/transformingtrauma. You can connect with us in many ways. On Instagram, find us under @the NARM Training Institute, on Twitter @NARM Training, and Facebook @NARM Training as well. The NARM Training Institute also offers the Inner Circle, an online self-paced learning program intended for anyone who is interested in joining an international online community focused on healing complex trauma. You can find more information about these trauma-informed learning programs in addition to other resources on the website, www.narmtraining.com. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Tori Essex for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community and connection with you and changing the world by transforming trauma.